inclined to forget about the clinical issues and talk to me about their fuller history. Professor List has also spoken about pain pathways. And I just want to come back over that a little bit and emphasize that when orofacial pain goes through all of these various pain pathways and registers on the somatosensory cortex, we know that the brain focuses on the orofacial area much more than it does elsewhere. For example, it's much more difficult to forget about an oral pain than it is to forget about backache. Now, most of us of a certain age have experienced backache. It just gets increasingly more common as you get older. And you can, to a certain extent, block out back pain if you're busy. But you'll also have the experience of a dentist of knowing, or even a personal experience, that if you have a little piece of food caught between your teeth, it drives you absolutely crazy. Now, that's a very simple thing, but the irritation, your brain will not allow you to forget what's going on there. So when we look at the literature that talks to us about what's going on at the somatosensory level and the somatosensory homunculus, how much of the brain is devoted towards the face and the hand, we see that it is true that there is a very large concentration at the highest level of perception on what's happening within the orofacial area. So it's a very powerful driving force for patients to seek treatment. One of the great blessings of the past 20 years has been the huge amount of information that we've had from functional imaging of the brain. Functional imaging is generally based on MRI scans that detect areas of activity and inactivity on the brain based basically on oxygen consumption. And it's a little bit like, looking at a street and watching lights going on in certain buildings, and certain areas light up with certain activities. And the brain is pretty much the same, that when we think along a certain way, when we experience a certain mood, when we experience a certain sensory stimulus, different portions of the brain light up. In the dental experience, we know that functional MRI of the brain has taught us a lot. We know that we can differentiate now between non-painful dental stimuli, such as percussion or mechanical stimulation of teeth. We can differentiate to a certain extent between chronic orofacial pain and acute dental pain. But one of the really interesting things when we get into this type of literature is the fact that when you have a very acute pain stimulus, all of you will remember that when you look at pain pathways, a painful stimulus enters the brain, whether it's from the spinal cord or the trigeminal area, and it crosses the midline and it registers on the opposite side of the brain. And for most painful stimuli, that's true. But with an acutely painful dental stimulus, both sides of the brain are stimulated. Now that means that the brain is really recognizing the presence of acute dental pain. So, maybe it is because, or maybe it explains why people with acute molar tooth infections or wisdom tooth infections are really driven to seek pain. Maybe why people with atypical odontalgia and other dental pains are really powerfully motivated to seek treatment, and why there's so much emotional disturbance, because physiologically it is affecting their brains. There are a lot of studies that highlight these differences, and we don't have time here to go through them, but we can for sure tell you that the patterns of brain activity that are associated with inflammatory disorders, and most jaw joint problems are inflammatory pains, sort of basic nociceptive type stimulation, and the other neuropathic pains that Professor List mentioned, like the nerve injury type pains, they fundamentally have different pathways in the brain. We don't know the details of all of these, but we know that they are different. So we react. The brain is reacting differently, and therefore the type of treatments that we provide are going to be very different. For example, if you give somebody who has jaw muscle pain or jaw joint pain an anti-inflammatory, you can expect to see some benefit. But if you give somebody with neuropathic pain or nerve pain in the orofacial region an anti-inflammatory, the chances are there'll be no response at all, because it's a different type of pain. Therefore, in our treatments, we look for specific drugs that target the problem. The really important issue here is to get the right diagnosis at the start. I want to emphasize, therefore, something that I do a lot for my students, which is to explain dental pain, inflammatory pain, or if you want to call it nociceptive pain. There is a slight difference between inflammatory and nociceptive, but for the sake of this lecture, I'll leave them as the same thing. They are different. When you stimulate a tooth, when the pulp is inflamed, it's inflammatory pain. But if the pulp is inflamed for a very long time, or if you do a root canal treatment, if there's an intervention, or you extract that tooth, the inflammatory pain can transform into what is called a neuropathic pain. And those two pains can overlap. There can be a neuropathic element and an inflammatory element. So when we're trying to gear up our treatment program, when we're making the diagnosis, we need to have in our own mind some recognition of what the basic pain mechanism is, and then try and calculate what is the best way to approach that problem with treatment. So specificity of the diagnosis is really important to us. Over the years, it's often been asked, because we know that toothache pain is straightforward and acutely inflamed pulpal pain, and acute pulpitis or irreversible pulpitis, we know that it stimulates the brain. But to what extent can it stimulate headaches? Headache disorders are a separate entity, but it's long been speculated that stimuli from the oral cavity may provoke a response in the brain. And in a simple way, this is very true. For example, in the past week, I saw a patient who went along to their prosthodontist to have a crown fitted. The patient was extremely anxious. The tooth was vital. The dentist removed the provisional restoration without giving the patient a local anesthetic. And it wasn't a big deal. I think it was done largely to expedite the process. But the patient was very, very uncomfortable while the provisional restoration was off and the permanent crown was being cemented. And then there was an increased stimulation when the permanent cement was put on. It was probably slightly acidic, and the patient felt some pain. That patient had the crown fitted, I think, on an upper right 6, and the patient went home and then developed a full hemicranial pain. Temple was sore, back of the head was sore, pain in the eye. And she was like that for about 2 days, and she went back to the dentist, and the dentist phoned me, and eventually I saw the patient. So what had happened there was that the patient had got a migraine attack, probably as a result of the stimulation from the oro-facial area. Now, migraine is a very specific entity in itself, but a lot of these disorders, like migraine and the neuralgias, they're all mediated by the same software, the trigeminal nervous system. The pain of migraine is mediated by the first division of the trigeminal nerve because it innervates the meninges covering the brain. So a very powerful stimulus from the orofacial region, whether we're doing surgery or just routine dentistry, can often provoke or destabilize an underlying condition. Here we have a case, a 38-year-old mother of 3 children. She had a 7-year history of episodic severe facial pain on the right-hand side. She was very, very clear that her pain always started in the molar region, in the maxilla, and the pain would spread again to the right eye, the right temple, and the back of the head. So straight away we're seeing that pain distribution is outside of the normal territory of the trigeminal nervous system. And that, as a clue, even if you're not an expert in orofacial pain, if the patient is experiencing pain outside the normal distribution of the trigeminal territory, then you've got to assume that there's something else going on that's not just dental, because dental pain very, very rarely radiates outside of the trigeminal nervous system. Taking the history showed that her pain was associated with nausea and vomiting. She had some balance problems. She was photosensitive. She did have some TMD symptoms on the right-hand side. She had a history of momentary jaw joint locking or jamming. And because the pain had gone on for so long, she had a history of using numerous occlusal appliances. And she'd actually had some jaw joint injections, and at one stage she'd had washout arthrocentesis of the right jaw joint. But it wasn't resolving a problem. This essentially is a headache disorder. This patient suffers from episodic migraine. And if I asked those in the room here to put up their hands, all of those who have ever experienced migraine headaches, I would expect to see probably 50% of the females and maybe 1/3 of males. The frequency of migraine attacks for females between the ages of 20 and 50 is 42%. So that's a really high percentage of headache in young female patients. It's going to be less in males, probably down to about 25% in that age group. But very often migraine as a headache pain is not easily recognized as a pain entity. So we have to ask certain questions because the pain can be facial. Migraine can present in the lower half of the face, that is beneath the zygomatic arch, between the zygomatic arch and the mandible. It can present as a problem in the oro-facial region. We ask for about photosensitivity. Are you sensitive to bright lights? Are you sensitive to loud noises? Do you have balance or dizziness problems? Do you suffer from hyperosmia? Are you extremely sensitive to perfumes, paints, petrol, very strong odors? Is your pain provoked by hormonal change? Are you weather sensitive? Does barometric pressure, barometric changes provoke the pain? Are there certain foods and certain stimuli? So in taking the history, we need to extend the history. If we're reasonably sure that it's not a dental problem, then these are the questions that help us target whether or not the patient has a headache or some other type of pain syndrome. Migraine is complex, and I'm not going to go into it in any great detail, but once you know about migraine, and it's a very easy thing to teach, it's very easy to ask the right questions. Typically, people who get these episodic pains, if you say, when the pain comes on, okay, it lasts for 2 or 3 days and it's very disabling, but it's a facial pain. How do you feel the day before? For some people, they'd say, I'm always elated, I'm always energized, and then the pain hits. Some people would say, I'm always very depressed, or I suffer from extreme thirst or extreme urination. There'll be physiological changes. So we can ask along these lines. Migraine aura is interesting for anybody that's ever experienced it. Often flashing lights, sometimes white lights, sometimes silvery lights, almost like a zigzag pattern in the corner of your eye, usually one eye affected. Very difficult to drive when it comes on, typically lasts for about 20 minutes, and very often is followed by a headache, but not always followed by a headache. If something like a migraine aura is prolonged, then they need to be neurologically investigated. But if it's only coming on for 10 or 15 minutes, then the risk factor is relatively low, and it is likely to be headache related. So when we're managing these patients from a pain point of view, and I know this moves away from our dental treatment, we certainly deal with the TMD issue with exercises and usually fairly conservative treatment if possible. But a big issue for a lot of our patients is overuse of analgesics, taking too many painkillers, so we have to restrict them to 1 day per week. We're looking at preventive drugs. Sleep disturbance is a huge issue for patients with chronic pain. How much sleep are you getting? Probably, most people in this room are getting about 7 hours of sleep, and the minimum requirement for us to function fairly well physiologically is between 7 and 8 hours. But it's not surprising that a lot of patients who have chronic pain problems suffer from sleep deprivation. They may be getting 3 or 4 hours of sleep at night time. They may be woken by a young child in the house, or the pain may be waking them at night time. Sleep deprivation affects your mood, it affects your function, it affects your quality of life. So for us as a team in treating these patients, we target sleep initially. We make sure we give them something to help them sleep, not just sleeping pills, because that immediately improves their coping capacity. So dealing with migraine is relatively straightforward. We get rid of the triggers, identify the triggers, we get patients to keep pain diaries, and we give them preventive drugs. And we try and choose preventive drugs that will have multiple functions, prevent the headache, get them sleeping well. Sometimes they're anxiolytic, they'll calm down the patients as well. There are a variety of what are called primary headache disorders. So migraine is one, cluster headache, chronic paroxysmal hemicrania. A primary headache disorder is one of the main headache disorders. And in men, cluster headache is not that unusual. If it typically presents in the temple and the eye, then they're not going to attend a dentist. They'll go to hospital or they'll go to their doctor. But if it presents in the oro-facial area, it'll present as an explosive toothache. It's like a grenade or a bomb going off in one of your teeth. This pain will often last for half an hour and then stop-start. So getting the rhythm or the tempo down on paper in the history is very important. When does it start? When does it stop? And getting that information in a clear way is often a challenge for patients who have a lot to tell you. And often our patients would prefer to talk about what their aunt or their uncle thinks rather than what you think. So you've got to keep them very, very focused. With a lot of these severe pains, you get something called autonomic nerve activation. And they're classically recognized in a number of signs. tearing of the eye, unilateral tearing on the side of the pain, redness of the eye, constriction of the pupil, a runny nose or blocked nose, a sense of swelling in the face, flushing of the face, etc. A sense of fullness in the neck because of carotid artery involvement. And if you can recognize that the patient is experiencing these autonomic symptoms, you think, okay, whatever is going on here probably is headache related because of the autonomic symptoms. And likewise, we have a series of conditions that are more female related, shorter bursts of symptoms. I actually saw one of these cases yesterday afternoon as an emergency. A patient getting excruciating pain in the mid-face, 5 or 10 minutes at a time, and occurring at its worst up to twice an hour. So really, really intense, absolutely the worst pain ever. This is 10 out of 10 pain. And the patient was referred to me by an endodontist who could see nothing there. I checked the patient's teeth. We looked at radiographs again. Absolutely nothing going on. A lot of these disorders, if they affect the face, and in the last year or so, I've started working with one of the neurologists here in the headache clinic in the Mater. And I've been absolutely amazed at how many of these facial pains the neurologists see. And so many of these pains could easily be interpreted as a dental disorder. So it's not surprising these patients have teeth taken out, they have root canal treatments, etc., that are unnecessary. And then lastly, we've got patients with chronic daily headache. And this is just another disorder. But the important thing about headache from a dental point of view, there are a couple of issues. Number one, headaches are associated with increased sensitivity to the environment, increased sensitivity to bright light, increased sensitivity to loud noise, and almost certainly increased sensitivity to dental stimulation. Particularly for somebody who's going through an acute attack of pain, their teeth are going to be a lot more sensitive because the branches of the trigeminal nerve are literally heightened in their sensitivity. So if somebody has a headache pain, or if they're very prone, or if they're getting repeated migraine or headache attacks, it's not a good time to be providing dental treatment for them. Likewise, if you, certainly in my experience, do vitality testing and electric pulse testing, chances are that you're going to get completely abnormal responses. Bring them back a week later and the same teeth are responding normally. We know that patients with headaches are much more likely to get neck pain because headache pain can effectively affect any part from the top of your shoulder to the top of your head, front and back of your face. Muscle recruitment with repeated headache attacks is important, and that brings us to an overlap with TMD. Patients with chronic headache disorders are much more likely to have muscle pain in the head and neck area and neck pain. And then there's increasing evidence that whatever genetics, and we certainly know now that the genetics behind headaches is very, very powerful, and it seems that genetics determine when the headache switches on, what type of headache it'll be, when it switches off, etc. But there's also some evidence to suggest that for some people with migraine or chronic headache problems, the headache will disappear over time, but these patients may get neuropathic pain. There's definitely a link, and that's something that's been looked at the moment. We see in the older patients, a lot of the patients getting trigeminal neuralgia have a previous history of migraine, etc. That has to be explored, but it seems to make sense that there would be a commonality with the genetic origin and the phenotype. Okay, I'm going to just finish now in the next 5 minutes. So neuropathic pains, nerve pains. Very quickly, here's a patient with shingles, and shingles gives you nerve pain, sharp shooting, stabbing pains, or a dull aching pain. But it's a viral infection. The virus damages the nerves. Here we have a picture of a patient having a facelift surgery. And these are always interesting, but a percentage of patients having surgery and having facelift surgery are going to have chronic pain afterwards. For a lot of those patients with facelift problems, the pain is along the distribution of the scar. It's along the length of the scar. The scar becomes hyperalgesic, allodynic, you'll have a degree of hyperpathia. So all of the things that we recognize that are associated with neuropathic pain exist in that area. Trigeminal neuralgia, I'm not going to touch on today. And then we have a whole load of neuropathic pains that are brought on by dental treatment. Dental treatment in itself is relatively safe because we use local anesthetic, and local anesthetic protects the nervous system. But repeated dental treatments, or dental treatment over a short period of time, the typical scenario is a patient goes away, perhaps to Eastern Europe or someplace else, and they get wall-to-wall dentistry, 4 quadrants of dentistry in a week. a lot of those patients come back with a variety of pains that are not dental. It's overstimulation of the nerve because dentistry was carried out too much too quickly. And more dentistry is not going to solve that problem. What you need to do in that case is to stop all interventions. Put the patient on medication that will calm down the nervous system, educate the patient, reassure the patient, and wait for it to settle over time. When I worked in Eastman, we did a study about 7 or 8 years ago on a group of patients that were coming through the endodontic clinic. We had 500 patients who came back with apparently normal radiographic findings after molar root treatment. And we looked and we said, well, if the root canal treatment looks normal, why is it? Are there characteristics that will highlight those patients? Is there any way that we can highlight people that are likely not to respond well? And there was a couple of commonalities. We highlighted the fact that if the patients had persistent, intense pain in the tooth side area for more than 3 months, that was a predictor of failure. You know, it wasn't a good sign. If they had a previous history of chronic pain somewhere else in the oro-facial region, previously, a previous bad experience, not a good sign. And being female was a risk factor. So important things. And we compare that to the medical literature, it's pretty much the same. Whether you're having spinal surgery or orthopedic surgery for replacement of the hip or any other type of surgery. So neuropathic pain, we see increasingly in dentistry, probably because it's being more easily identified and more people are educated towards its presence. Obviously, there are a huge number of implant cases. If given the number of implants, I can't remember the figure for the number of implants in Ireland, but it's very high if you combine the figures from north and south. So a small percentage of patients who have implants placed are going to have some degree of tissue destruction and they'll develop pain afterwards. And usually that pain is neuropathic. A lot of the research on neuropathic pain and injury-related pain is done by Tara Renton, maxillofacial surgeon, and I would refer you to a lot of her literature and some of the recent publications in the last 2 or 3 years if you really want to go into neuropathic pain and nerve injuries in the orofacial area, because her work is excellent. I'm just going to move on a little bit. I'm going to finish with a case here. This is a patient who had 6 veneers placed, a young woman who was a single parent. She went along to her dentist. The dentist prepped the teeth. Now, she had a pretty miserable life. She was only 28 years of age. She was bringing up a child. She had very little money, and she was really unhappy about her appearance. She really reckoned, I guess, that if she went along and had the veneers done, it would be a great boost to her life. So she saved up enough money, had the veneers done, and unfortunately she had a series of problems during the preparation. The temporary restorations came off a couple of times. Her teeth were incredibly sensitive. Her dentist had sent away the veneers outside of the country to have them made, and there was a delay in getting them back. And she went for quite a period of time with and experienced a huge amount of pain with no provisional restorations covering the teeth for a series of reasons. Eventually she developed persistent severe pain in both central incisors. That pain was in the upper centrals, severe, burning, aching. Burning, aching, certainly burning is more suggestive of neuropathic pain. And the onset was almost immediate after the dental work. Eventually that patient had root canal treatment on both central incisor teeth. Her general dentist did it twice. She was referred to a specialist endodontist, and eventually the endodontist said, look, can you have a look and see what's happening? And she had numerous courses of antibiotics. This patient had a pretty classical neuropathic pain setup. She had widespread sensitivity in the premaxilla, bilateral. The sensitivity on sensory testing extended well beyond the central incisor teeth. And again, the somatosensory testing, light touch with cotton bud, pinprick, etc., testing for cold, all suggested that there were significant abnormalities in the sensory testing of the teeth. Now, just draw your attention to one thing. As dentists, we're very used to sensory testing because we test the vitality of teeth and have done traditionally for years and years. It's a different concept to test the sensitivity of soft tissue, but you have to test the sensitivity of soft tissue to determine whether or not neuropathic changes are present. This is just another case that we're going to go back to. What I would suggest about this case, neuropathic pain in a clinical environment is very difficult to treat. essentially, if you look at the studies, we have a list of drugs, mostly anticonvulsants and some antidepressants that are effective, but only to the extent that they're 50%. 50% of patients will respond to drugs. That's not encouraging. It's very, very difficult to treat. We have nerve blocks. We can provide patients with psychological support. You know, the overall behavioral approach to these patients is very, very important. But at the end of the day, many of these patients are living with persistent severe pain. One of the things that we're researching at the moment, and we're doing a study on this, is the use of electrical stimulation of nerves, because we know from the treatment of spinal pain that if you electrically stimulate the nerves in the spine, you can block pain. The use of electricity, placing a probe underneath the skin, or in fact we're now placing it in the temple just beneath the zygomatic arch, where you can stimulate both the maxilla and the mandible together. It's encouraging. It's showing that we're taking patients with pain that's 9 out of 10, finding it difficult to live, taking the pain down a couple of notches. So this is work in progress, but the reality is neuropathic pain in the orofacial area presents a real challenge to clinicians and researchers. Okay, I'm going to stop there, I think, for time-wise. Thank you very much.
Thank you, Dermot. As always, a beautifully crafted lecture. I think we're really very fortunate, Dermot, to have somebody of your calibre in this country to be able to refer patients to. So we really appreciate you taking the time to put together such a beautiful lecture for us. Thank you. Our final lecture today is to welcome back Thomas List again. And Thomas is going to speak this time about evidence-based management of orofacial pain.
Thank you very much. And I'm trying to bind together what we've been talking about this morning by Dr. Kevin and by me. I think we started out, we've been talking about how common orofacial pain is. We have talked about different classifications, TMD. We've talked about now neuropathic pain, different sort of headaches. We also cover the area how to do examination, and to look at the patient's both biological part and also do an assessment of the psychosocial part. So the question is then, okay, the patient's in front of you, what's the next step? What is the evidence then for the treatment? So this is what I'm going to try to cover next here. And I think it's quite important to highlight once again, prevalence 10 to 15%. If you ask the patients, do you have a perceived need for treatment? Are you willing to pay for the treatment? The majority of them will say yes. Most of these patients are supposed to be treated of you as a general practitioner, and I think that you will be able to help most of these patients. Only the top of the icebergs will be taken care of specialists. So in the flow of the decision making, I think it's in a basic general practice, it's obvious you can't ask all the patients and do examination all the patients. You have to have a quick screener, and there's been some screeners which have been suggested. In Malmö we use a quick screener of 2-3 questions where we ask the patients, do you have pain in the temple, face, or TMJ once a week or more often? Do you have pain when you chew and open your mouth? If they say yes, then we go ahead and take the next step. There's other screeners, but I think it's very efficient to have a screener because the screeners are shown to have a high sensitivity and specificity, which means that you pick up most of the cases who have the pain and also most of those cases who have a perceived need for treatment. If you pick up one by the screener, okay, then take the next step, which for example, for a patient with temporomandibular disorders would be, for example, that you use the DCTMD, you do a clinical examination, you ask the patient to fill in the questionnaire so you have a complete picture of the patient. And on basis of the data you have, then that's the next step. Do you going to treat the patient yourself or do you refer the patient? So when we come to treatment, we all talk about evidence-based practice. And Dr. Kevin mentioned before about systematic reviews. the evidence for a certain treatment. And obviously it's really important to have the evidence which is clinically relevant research that's been conducted using sound methodology, which means that you have vacuumed the literature regarding a certain area and you pool data and see how effective is the treatment. Yes, that's obviously one pillar when it comes to evidence-based practice. But also in addition, it's the clinician's cumulated experience and clinical skills, and not at least the patient's personal preferences and unique concerns regarding expectation values. It's no point to suggest some sort of treatment to a patient, some medication, if they're not going to use it. So you need to educate the patient, and you have to have an alliance. Evidence-based medicine is these three things together. So the next step is then that I'm going to refer to the Swedish national guidelines, because there was a major undertaking in Sweden by the medical authorities, by the Swedish Health and Welfare, where they actually used dentistry as a model in medicine. And 7, 8 areas in dentistry was perio, was pros, ortho, oro-facial pain, and so on, where big groups were established where we have to vacuum the literature regarding evidence. So we looked for what is the effect of certain treatments here. So we looked for the evidence using grade. That's the same thing as systematic reviews, which you have seen otherwise. But in addition, we took one step further. We did not only look for the evidence, we also looked for health economy, and we also had to put in the severity of the conditions, because in Sweden, part of the dental care is subsidized by the ministry. So the authorities were very interested to know where money should be allocated, and they also wanted the highest evidence for treatment. So altogether that was an equation, which meant that suddenly gingivitis had to be compared with a luxation, or a crossbite with oro-facial pain. Everything was put into the same basket, because they want to know, where do we put our money? So there was a big struggle between the different groups, where they actually had to decide what the severity was. For example, luxation, very severe. The patient sits in a chair and can't close the mouth, would come to a 2 or 1. So 1 is most severe, and if it's down to 10, it's very low severity. And that was then multiplied against the evidence in the literature and how much cost it was. So, for example, TMD, temporomandibular disorder, was judged to be a score of 4. So was there good evidence in the literature? Either it could increase a little bit or stay at the 4. And did it cost very much? Then it dropped. And was it good cost benefit? Then it stayed or could even increase. So all 3 things were taken together in order to give them a priority score. So what I will do now is I'm going to pick out some treatment forms, and I will start with behavioral therapy. And behavioral therapy could be everything from information, counseling, education of the patient, could be relaxation, breathing exercises, or even biofeedback, where you actually measure the activity in the muscle, and you can have a digital display and give a feedback to the patient how the activity is in the muscle, or cognitive behavioral therapy. So there's a number of different therapies in this group. What came out of these the score which came out was actually very high, 4. It turned out to that For chronic pain in the face and jaws, behavioral treatments such as biofeedback and cognitive behavioral therapy have better effect than no treatment. There was a number of studies which shows that CBC, cognitive behavioral therapy, worked as well as, for example, splints, and it was give an additional effect if you had this as a complementary. So it was actually a high score for behavioral therapy. Next area was physical therapy, which could include both motor activity and also sensory stimulation. Motor activity could be, for example, jaw exercises, stretching. Sensory stimulation could be heat, cold, postural training, could be acupuncture, TENS, ultrasound, laser, and so on. High score was found for jaw exercises and stretching. The conclusion was that jaw exercises and stretching have a moderate effect on pain and moderate effect on impact on global improvement. And actually turned out to that the documentation regarding jaw exercises and stretching was quite low. But since it's quite cost effectively, you sit down with the patient, you instruct the patient can work themselves and do it. Actually, the economic part improved the score. Okay, next area, acupuncture, sensory stimulation, old therapy, which has been, there's a documentation more than 2,000 years back, a lot of documentation from China, and actually acupuncture is used very different in different cultures. In Sweden, actually out of the patient with chronic pain, 40% of the patient will report that they have received acupuncture at some point. So acupuncture is quite common because it's been incorporated within the medical systems. It's very common that physical therapists, for example, provides acupuncture. In Sweden, however, also dentists, nurses, physicians are doing it, but mainly physical therapists. In Denmark, for example, approximately 20% receives acupuncture. I don't know how it is in Ireland, but it depends on the culture how common it is. Acupuncture, as you can see here, the conclusion was that acupuncture has better pain relief in various types of facial pain than no treatment equivalent efficiency compared with other treatments, which means that there are studies with the limitations of these studies. We actually show that acupuncture was as effective as occlusal splints. But the thing is, if you receive acupuncture, you have to go get acupuncture 8 to 10 times 30 minutes. So the costs were actually higher than if you would provide a splint. So therefore, it drops from a 4 to a 6. When you talk about treatment, it's not only the beneficial part which you talk about. You also talk about side effects. And I want to stress that acupuncture is actually a very safe method. This rarely happens that patient report any adverse events. If there are any adverse events, what they will report is that they feel more tired, they will get some blue marks, hematomas, and transient increased pain. But, and I want to stress this, major adverse events has happened. If you look in the literature, needles have been put in most any organs in the body. There's been reports of pneumothorax. It's been a report of actually deaths also. So yes, it's important if somebody receives acupuncture, they have to receive acupuncture from somebody who has good education. In Sweden and in several other European countries, you have those within the health system which has the anatomical knowledge and the medical expertise which provide acupuncture. But you also have acupuncturists in the town who may not have medical treatment. So you have to be aware of that the one who provides the treatment knows anatomy and has medical education. So when it comes to acupuncture, yes, this is an option for you. If you have a patient who has not responded to splint, has pain, yes, you can refer this person to acupuncture, but be sure this is a person who has proper knowledge. We looked into low-frequency laser, low score because the effect was actually fairly poor. Okay, another area, occlusal appliance, is probably the most common therapy which you also would provide your patients. And there's a number of different splints. And here's just a few of them, like the occlusal stabilization splint or Michigan splint. You have the mandible advancement splint for patients with clicking and pain of the joint. You have partial splints like the NTI splints or the relaxed splint, which you see in the middle here, in the lower row, or you have a soft splint or relaxation splint. If we start with the stabilization splint, actually it received a high score. There's been quite a number of studies, whether you compare occlusal splint with other splints or placebo or splints with placebo splints and so on, or compared with waiting list. Anyway, conclusion, moderate effect on pain, moderate to high effect on global improvement, and even increasing in. So actually, the stabilization splint received a high score. It's biological, very friendly. It's orthopedic appliances which helps a lot of patients, and there's rarely reported any side effects. Soft splint, lower score, even though when you looked at the differences between the splints, you compare soft splints with hard splint, you don't see much difference. There's no significant difference. You see some trends, but there's no significant difference. But since the durability is lower, the indication was lower also. Indication, when would I use a splint? For example, in the mixed dentation, or somebody who wants to use it for a short time would be an indication for this kind of splint. Partial occlusal splint, you have the anti-eye splint. Actually, there's a few studies which have compared the anti-eye splint with other splints. And if you look at those studies, you can see that there doesn't seem to be a significant difference. On the other hand, and I want to stress that, is that actually there's been a report of more side effects with this splint, such as occlusal changes. So if a splint does not have a better effect, but the risk is that there are more side effects, what's the benefit? So the indication, as I can see, are quite low. In the literature, there has also been a lot of discussion if it's possible to inhale this little splint. Actually has not been any reports that actually has happened, even if you hypothetically can think it might happen. And if you then want to do a splint, and it has to be at one occasion, I would then prefer the relaxed splint, because it's from 1.3 to 2.3. It's not possible to inhale that one because it's a little bit larger and has exactly the same indications. Occlusal adjustment is also therapy which probably 20, 30 years ago, those of you who have education long back, this was a main emphasis at the dental school. This was what we were trained to do through and actually there's been a lot of investigation in this area where we have looked into the occlusion and the malocclusion as a risk factor for TMD. And to make it very short, because this is a lecture by itself, is that the explanatory factor for malocclusion or occlusal factor is 15%. So 15% that somebody develops TMD can be related to occlusal factors, 85% to other factors. So yes, it is an important factor. As dentists, we are the only one who can diagnose this, and we're the only one who can examine it. Yes, we should do it, but at the same time, we look at it differently today than before. It's not emphasized as much as it was before. So when we look at the first here, occlusal adjustment, actually we got a higher score. But if you read here, there's a high effect to improve chewing and mastication with occlusal adjustment if there are extensive distractions in the TMG following an ascites, for example. That means it's a TMD which results in an occlusal change. You have had an inflammation, you have changes at the condyles, which then will open up the bite. Obviously, if you then look at these pictures, you can, by doing occlusal adjustment, you can improve the chewing ability. But on the other hand, if it's the other way around, could it be that occlusal factors such as occlusal interferences, should they be adjusted in order to then treat myalgia? Actually, you see this very low score. There's a number of studies where patients have been then allocated to either occlusal adjustment or to placebo or mock adjustments where you have just a rubber. Was no difference between the two groups. So that's why actually was a low score for doing this intervention if you have then, for example, myalgia. Pharmacological treatments. You have everything from NSAIDs to antidepressants and neurontins. High score for glucocorticoids if you have arthritis in the TMJ. So when you do the interarticular injection, you can inject them glucocorticoids. If you do this injection, that works very well, but you have to be experienced to do that. In Malmö, where we receive those patients, we actually get it from the rheumatologists. They are very experienced and good to injecting other joints, but they find it difficult to go into the TMJ. So we get the patients. So if you inject, you actually have to go in about 1.5 centimeter in order to find the joints. So you have to be experienced to do this. And you have to do it routinely to do a good job. NSAIDs, also high score, works well. Actually, there's only a few studies done in the oro-facial pain area, but we have to lean on what has been found when it comes to similar pain conditions in the body. However, to prescribe NSAIDs for a long time is not very good because of side effects in the gastric interstitial system. So avoid that you get ulcers in the stomach and so on. So yes, NSAIDs are good, but you provide in a short term, or if it's a breakthrough pain. Somebody has chronic pain and suddenly they have a breakthrough pain, yes, do it short, but not long prescription. Paracetamol, slightly lower score. We know that the paracetamol is very friendly. What we do is that we use paracetamol, but then we try to do it together with NSAIDs to have a combined effect, because the mechanism are differently, and you can then get a better effect of the drugs. We talked about neuropathic pain. You heard about atypical odontalgia by me previously, and also by Dr. Dervan. And one possibility is to try topical lidocaine cream, because if you have neuropathic pain, like diabetic neuropathies, you use patches with EMLA, lidocaine. Seems to work very well. You can't put the patch in the mouth, so what you do is that you use a soft splint where you can attach the cream underneath the splint. So the splint is used like plaster, you could say. And it keeps the drug in place. You use it 3 times daily for 30 minutes during a month. Some patients will respond favorable to this, and some not. Approximately about 30%. That's what, anyway, the few studies which have been performed. But that's a possibility. The good thing with this drug splint, so to say, is that it does not have any systematic effects. So it's worthwhile trying for patients with neuropathic pain. Weak opioids, low score, because of the dependency, and you all probably recognize the very sympathetic doctor down to the right, and you've probably seen this on TV. He's taking OxyContin, and it's the dependency you want to avoid, the dependency of the drug. Actually, opioids work well for certain neuropathic pain conditions, but the dependency is something which you have to be very aware of. High score for tricyclic antidepressants, particularly if it's chronic pain, including fibromyalgia. But what is important then to know when it comes to tricyclic antidepressants is that you have to titrate it slowly to be sure that you get a beneficial effect and not too much side effect. You will get side effect, increased weight, dryness in the mouth, and so on. In Sweden, as dentists, we are not allowed to prescribe it. I know that the different rules in different countries in Europe. What we do is that we do it together with the physicians. Antiepileptic drugs, also a high indication, but that's for neuropathic pains. Also done in Sweden together with the physicians. And then the final area is TMJ and maxillofacial surgery, which can perform different ways. You can do lavage, which is rinsing of the joint. It's, if you point to this, it's the here, where you go in with 2 syringes and you rinse it with saline. Or you can go in and have arthroscopy, which means that you go into the joint. You can see in the joint if there's any inflammation. If there are any adhesions like this, you can go in and cut the adhesion and then rinse it out. Or if the disc is really damaged, you can go, let's see if I can get this one to go. No, it doesn't want to come. Anyway, the last picture up is an open surgery where you can go into the TMJ and you can open up and you can remove the disc. Score very high. You can see for discectomy, taking out the disc. For disabling symptomatic disc displacement with reduction, which has not been improved by reversible treatment. And this I want to emphasize because this is important. This was, we had a long discussion with the surgeons, so actually the surgeons came up to this in collaboration, and what they also emphasize is these patients who, for example, have a locked jaw, they have to be treated first conservatively, at least for 6 months. Because we know that most of these patients will respond well to the treatment. Now, after 6 months, if the patients have not responded and the pain is disabling, at this point, then we can take the next step and do surgery. But it's really important that all these patients are first taken care of conservatively before we take the next step.
Exactly. Yeah.
And there was also high scope for arthroscopy in the same way for disabling symptomatic disc displacement without reduction, which has not been improved by reversible treatment. That means that we try to have a step ladder where we start out with, when it comes to treatment, first as less invasive as possible, which means arthroscopy. If that doesn't work, okay, the next step is then doing discectomies. If you do these surgeries, which in Sweden is very low, probably somewhere between 0.5% of the patients, so low percentage which go to surgery. But, and I want to emphasize, the correct patient, this is a very good treatment. I mean, they will respond very well. But if you do, for example, discectomies, it's not just going in and then go out afterwards. I mean, there's a lot of physical therapy, and the patient will say, before I had clickings and I had pain, today I don't have any, for example, any sound, or I don't have any clickings, which I used to have before, and the pain is much less. I still have some pain, but it's less pain, but now it sounds like if I had sand in the joint, because you're going to get remodulations of the joint. So it's important that you inform the patient about this. So when it comes to the decision making, just to summarize it, first a screen, if yes, and the patient wants treatment, make a thorough examination, and then I think that the core of treatment among general practitioners should be behavioral therapy, counseling, information, education. You get really far with that. You should use drugs like NSAIDs, paracetamol. You should instruct the patient in proper jaw exercises, and I think that occlusal appliances work very well for some patients, particularly those patients will report more pain in the morning. If it's more pain during the day and afternoon, okay, then it's more behavioral treatment. So you have a little bit to guide here. And then if, as I mentioned before, also occlusal adjustment, if there's indication for that. And if you don't, if you have tried this and the patient doesn't respond, okay, then you do refer whether then the specialist or other therapists can do additional therapies, as you can see here. So what the message is that when you have patients with orofacial pain, I think it's like a dentist. So you have a drawer. In the drawer you have different drills for doing when you do your cavity. You don't only have one drill. So, and you have to have some sort of clinical intuition. What sort of drill are you going to use? And the same thing is when it comes to orofacial pain. It's not one set of treatment. You have to listen to the patient, see the patient, assess the patient, and according to that, decide, is this going to be behavioral therapy or the behavioral therapy combined with occlusal appliances, and how should I do with your exercise? So you have a core of instrument, and you have to guide that towards the patient in the best way you feel. With that, I want to thank you very much.
Thomas, thank you very much. It's been both an honour and a privilege having you here today. I'm delighted to have been able to welcome you to Dublin yet again. Ladies and gentlemen, I think that we need to have some discussion now. I notice that there are some dental students in the audience, there are some oral surgeons in the audience, and there are many other people. Would anybody like to raise a question? And because we have our audience still watching us in Malmo, I'd like to use a microphone so that they can still hear what's going on. So are there any questions in the audience for either Dr. Canavan or Professor List?